Hello, and welcome to tonight's webinar, Preparing for Zika Transmission in the United States. My name is Angela Fisher, and I'm the Clinician Outreach and Partnership Coordinator for the Division of Healthcare Quality Promotion at CDC, and I'm currently serving on the Zika response detail. The mission of DHQP is to protect patients, protect healthcare personnel, and promote safety, quality, and value in both national and international healthcare delivery systems. This webinar is part of a series of infection control-related webinars that CDC will be hosting with a variety of external partners and experts. Before we get started, there are a few housekeeping items that we'd like to cover. First, we welcome your questions. Please submit any questions or comments you have via your chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Your Hand button located on the top left-hand side of the screen if you need to chat with a meeting chairperson for assistance. For example, technical difficulties you can't hear during the webinar. As a reminder, the audio for today's conference should be coming through your computer speakers, so please ensure that your speakers are turned up on the volume. The CDC speakers on the webinar today feature Dr. Susan Hills, Medical Epidemiologist, Arboviral Diseases Branch for the Centers for Disease Control and Prevention, and Dr. Kieran Perkins, Medical Officer, the U.S. Zika Pregnancy Registry, Pregnancy and Birth Defects Task Force, Zika Virus Response, also at CDC. Now it is indeed my pleasure to introduce Dr. Andrew Gurman, President of the American Medical Association. Dr. Gurman, we'll turn it over to you.
Thank you very much, and good evening, everybody. Thank you for joining the AMA and the CDC's Zika virus webinar today. As the Zika outbreak continues to evolve and more Americans become impacted by the virus, it is very important that our nation's physicians and all clinicians are prepared to handle the possible cases of the virus and are equipped with the most up-to-date information to answer patients' questions. This evening's call will provide each of you with an update on the latest epidemiological and clinical aspects of the current Zika outbreak, implications for pregnant women, and the CDC's latest clinical guidance to support you in combating and preventing complications from the Zika virus. We are pleased to have two representatives from the CDC with us today, CDC Medical Epidemiologist Dr. Susan Hills and CDC Medical Officer Dr. Kieran Perkins, to provide you with the newest information and developments on Zika. Following their remarks, both speakers will be available to answer any remaining questions you may have related to Zika. In the weeks ahead, the AMA will continue to update our online Zika Virus Resource Center, and you see the link up there on the screen, which can be found on the AMA website and at the AMA web address appearing on the screen, with the latest Zika-related information from the CDC and other trusted healthcare organizations. Again, welcome to all of you, and I will now turn the call over to Dr. Hills and Dr. Perkins from the CDC. Thank you very much.
Thank you, and thank you for the opportunity to discuss Zika virus disease on today's call. I'm going to commence with some information on Zika virus and its transmission. Zika virus is an RNA flavivirus related to dengue, yellow fever, Japanese encephalitis, and West Nile viruses. Transmission to humans is primarily by Aedes stegomyia species mosquitoes. And infection is typically asymptomatic or causes a mild dengue-like illness. However, importantly, recent outbreaks have identified new modes of transmission and clinical manifestations. Aedes aegypti is the primary vector for Zika virus transmission, but Aedes albopictus is also a competent vector. These mosquitoes also transmit dengue and chikungunya viruses. They lay their eggs in peri-domestic water containers and live in and around households. Their peak feeding time is during the daytime, but they do also bite at night. And of the two, Aedes aegypti is the more efficient vector for humans. This map shows the approximate distribution of the respective species and where their distributions overlap. You can see the blue shaded area, and that pertains to Aedes albopictus. The orange is Aedes aegypti, and the brown represents areas where both are present. In addition to mosquito-borne transmission, other modes that have been documented include intrauterine, resulting in congenital infection, intrapartum from a viremic mother to her newborn, sexual transmission through laboratory exposure, and through blood transfusion. Other possible modes of transmission include organ or tissue transplantation and breast milk. I'd now like to move on and describe some of the epidemiology of Zika virus as some background, as well as some important aspects of the current Zika virus disease outbreak. So Zika virus was first isolated from a rhesus macaque in Uganda in 1947. Before 2007, only sporadic human disease cases were reported from Africa and from Southeast Asia. However, in 2007, the first Zika outbreak was reported on Yap Island, which is in the Federated States of Micronesia. And subsequently, in 2013 to 2015, more than 30,000 suspected cases were reported from French Polynesia and other Pacific islands. In May 2015, the first locally acquired Zika virus disease cases in the Americas were reported in Brazil. And as of July 28th this year, 42 countries or territories in the Americas had reported to the Pan American Health Organization, or PAHO, that they had active local Zika virus transmission. This map shows the distribution of countries or territories with reported active Zika virus transmission as of August 2nd this year. The number of locally transmitted Zika virus disease cases reported to PAHO by countries in the Americas from January 2015 to July 2016 is now in excess of 500,000. Although only about 20% are laboratory confirmed due to limitations in testing capacity in some of the countries in the region. Most suspected and confirmed locally transmitted cases reported to PAHO as of May this year were reported from South America, followed by the Caribbean and then by Central America. Locally here in the United States, from 2011 through 2014, 11 laboratory-confirmed Zika virus disease cases were identified in travellers returning to the US from areas with local transmission. However, with the current outbreak in the Americas, the cases among US travellers have increased substantially. The data presented in this slide and the next pertain to cases of laboratory-confirmed Zika virus disease that have been reported to ARBONET, which is CDC's arboviral disease surveillance system. Between January 1, 2015 and August 3rd this year, there were 1,841 travel-associated cases reported, and that included 1,818 from US states and 23 from US territories. And these data are presented in the first column on this table on this slide. These travel-associated cases include travellers returning from affected areas, their sexual contacts, or infants infected in utero. And the figure includes 16 sexually transmitted cases in contacts of travellers and 5 cases of Guillain-Barré syndrome. Over the same period, which is presented now in the second column on the table, there were 5,531 locally acquired cases reported to ARBONET, or these are cases where transmission was presumed to be mosquito-borne. The figure includes 6 cases from the state of Florida and 5,525 from US territories. In addition to these cases, there was also one case acquired through laboratory transmission. The state of residence for US travel-associated cases is shown on this map, and overall 45% of cases were reported from just two states, New York and Florida. So I'll now move on and discuss the clinical presentation of Zika virus disease. Most Zika virus infections, as I said earlier, are asymptomatic. When clinical illness occurs, it's usually mild and characterized by rash, fever, arthralgia, or conjunctivitis. Symptoms typically last several days to a week, and severe disease requiring hospitalization is uncommon. In addition, fatalities are very rare. Based on data reported on US travel-associated Zika virus disease cases, rash seems to be the most common feature that we see. As you can see in the table here, it was reported in 76% of patients in comparison to fever that was reported in 60%, and then arthralgia in 47% and conjunctivitis in 31%. However, the reported data were unfortunately not complete for all these symptoms, so these percentages might not be completely accurate to reflect the frequency of these symptoms, but certainly give the idea that probably rash is the most frequent symptom that's reported. Recent outbreaks have identified clinical manifestations not previously recognized in association with Zika virus infection. These include fetal loss, microcephaly, and other congenital anomalies, which will be discussed in more detail by Dr. Perkins. Other manifestations include Guillain-Barré syndrome and other neurological syndromes, and there have also been anecdotal reports of meningoencephalitis, myelitis, and ADEM. In addition, thrombocytopenia has also been reported. The differential diagnosis for Zika virus disease includes other arboviruses, in particular dengue and chikungunya, which have very similar clinical features, as well as other viral and bacterial infections as listed on this slide. Because it's difficult, if not impossible, to clinically differentiate Zika virus disease from other infections, including dengue and chikungunya, diagnosis relies on laboratory testing. Zika virus diagnostic testing includes RT-PCR to detect viral RNA in serum and urine collected less than 14 days after illness onset. RT-PCR can also be used for the detection of viral RNA in amniotic fluid and semen. However, the diagnostic utility and implications are still under evaluation. Serology for IgM and neutralizing antibodies can be performed in serum and cerebrospinal fluid samples, and if tissue samples are collected, they can be tested by immunohistochemical staining and also RT-PCR for viral antigens and RNA. The testing recommendations do vary based on several factors, and this includes whether, if it's a woman, she is pregnant, whether the person has any symptoms, and the time from symptom onset to sample collection. And I've included a link on this page to current CDC testing recommendations. So who should be tested for Zika virus infection? Testing should be performed on a patient with fever, rash, arthralgia, or conjunctivitis whose symptoms started either during or within 2 weeks of travel to an area with ongoing transmission, or who has an epidemiological link to a laboratory-confirmed case through vertical transmission or sexual contact. Testing should also be offered to all pregnant women, including asymptomatic pregnant women, with a history of travel during their pregnancy to an area with ongoing transmission or sexual contact with a partner. And again, Dr. Perkins will discuss recommendations in more detail, and providers should contact their state or local health department to facilitate testing. There is no specific antiviral therapy for Zika virus disease. Treatment is supportive and includes rest and administration of fluids, analgesics, and antipyretics as necessary. As alluded to earlier, suspected Zika virus infection should be evaluated and managed for possible dengue or chikungunya virus infections. And notably, because it's important that dengue be ruled out, aspirin and other non-steroidals should be avoided until dengue can be ruled out to reduce the risk of hemorrhage. Zika virus disease and Zika virus infection, including congenital Zika virus infection, are nationally notifiable conditions. CSTE approved an interim case definition in February this year, and subsequent to that, revised definitions were approved in June. So healthcare providers are definitely encouraged to report suspected cases to their state or local health departments. What timely reporting allows is for health departments to assess the cases and investigate and reduce the risk of local transmission or mitigate further spread. Unfortunately, at this time, there are no vaccines or medications to prevent infection or disease. The primary prevention measure is to reduce mosquito exposure. CDC has also issued recommendations advising pregnant women to consider postponing travel to areas with ongoing Zika virus outbreaks. In addition, if patients do have Zika virus disease, they should be advised to prevent mosquito exposure during the first week of illness to prevent further mosquito-borne transmission to others, given they can be viremic during that period. Finally, I wanted to give a brief overview of the reported local transmission of Zika virus in the continental United States, which has occurred in Florida and has attracted some attention. So on the 29th of July, the Florida Department of Health announced that one neighborhood in Miami-Dade County, just north of downtown, had local transmission of Zika virus, or that is, an area where Zika virus was being spread by mosquitoes. The specific area is provided on the Florida Department of Health and also on CDC websites. As of August the 3rd, 12 cases had been reported, including 2 index cases, 4 associates of these cases, and 6 asymptomatic persons who were identified in a community survey conducted within a 150-metre radius. However, to provide a large margin around the common location, the area with local transmission was defined as a 1 square mile area. In addition, 3 other cases of local transmission were investigated or being investigated as of August the 3rd. These included 2 isolated cases in Miami-Dade and Broward counties where surveys were conducted and there was actually no evidence of further transmission. And there was also 1 additional case in Miami-Dade County that was under investigation. In response to the identified small area of local transmission of Zika, the Florida Department of Health has implemented several measures to identify and reduce the risk of any ongoing local transmission, and CDC has provided support for some of these efforts. These include enhanced surveillance for cases, including surveys to detect additional cases, including asymptomatic cases. There's been intense mosquito surveillance and control activities, including backpack, truck, and aerial spraying. Screening of blood donations by the blood bank servicing the affected area has been implemented. There has also been release of guidance for pregnant women to avoid non-essential travel to the 1 square mile area. And if travel is essential, measures to protect against mosquito bites should be used, including wearing insect repellent, long clothing, and limiting time outdoors. In addition, testing was being offered to pregnant women who live in or travel to the 1 square mile area or had unprotected sex with a partner who travelled to or lives in the area, with a relevant period of time being after June the 15th. The local transmission of Zika virus in this area is being monitored very closely. We have been asked about the likelihood this outbreak will be ongoing, and predicting the degree of any local transmission and any ongoing transmission is very difficult, as many different ecological, environmental, and human factors influence the likelihood of any transmission. And they include factors like weather patterns, type of housing, the actual presence of breeding sites, how frequently air conditioning and screens are in use in the area, and also human behaviour. These factors influence the number of mosquito vectors around an infected person and the likelihood of the vector biting another person, and therefore the size and scope of any outbreak. What we do know from experience with local transmission of dengue and chikungunya, which are, as I mentioned earlier, other viruses transmitted by Aedes mosquitoes, that when local transmission has occurred in the continental United States in recent years, it was of limited duration and affected very few people. And as an example, in Florida in 2014, there were a total of 12 locally acquired cases of chikungunya reported, but only 2 appeared to be linked, and there was no long-term transmission. We can probably assume that dengue and chikungunya provide a good predictive model, and what that suggests is that it's very unlikely that the Florida outbreak will be prolonged or intense. However, of course, we can't predict the extent of any local transmission of Zika virus with complete confidence due to the variety of factors that can influence transmission that I referred to earlier. Other factors that need to be taken into consider is that there is actually extremely heightened surveillance for Zika cases, which means that it will be very sensitive in identifying additional cases. Although also importantly, there are intensive vector control efforts that are likely to have a major impact on limiting the outbreak. So finally, on this slide, I have listed a few helpful resources. Thank you, and I'll now hand over to Dr. Perkins to discuss implications of Zika virus infection for pregnant women.
Thank you, Susan. Good evening. I will now present Zika virus in the context of implications for pregnant women. Today's Zika outbreak is unprecedented. Although Zika virus has existed for almost 70 years, the potentially devastating effects on pregnancy are really a new phenomenon. We are literally learning more about Zika and what it means for pregnant women every day, and CDC's top priority for this public health response is pregnant women and their fetuses. Pregnant women can be infected with Zika through the bite of an infected mosquito or through sex with an infected partner. If a woman is infected with Zika around the time of conception, the risk to the fetus is currently unknown. However, from what we do know about other viral infections, infections around the time of conception can potentially lead to infections in the fetus. If a woman is infected during pregnancy, Zika virus can be passed to her fetus during pregnancy or around the time of birth. We currently have limited information on Zika virus. The incidence of Zika virus infection in pregnant women is actually not known, but we do know that Zika virus infection can occur in any trimester. There is no evidence that pregnant women have more severe disease compared with non-pregnant people, and we have no evidence that there is increased susceptibility to Zika virus in pregnant women. So what do we know about the effect of Zika on fetuses and infants? Researchers have found evidence of Zika virus in fetal tissue, such as amniotic fluid, placenta, fetal brain tissue, and products of conception from pregnancies among women with Zika virus infection, which does provide some evidence of the association between Zika virus infection and poor pregnancy and birth outcomes. For example, studies in a CDC laboratory have found evidence of Zika virus in the brains of newborns with microcephaly. And in this magnified image of brain tissue, the circles indicate where Zika virus was detected, as indicated by dark pink stain. Zika has also been found in the placenta in early miscarriages. There have been numerous reported brain abnormalities with congenital Zika virus infection, which you can see listed here. but microcephaly and intracranial calcifications were the first abnormalities identified. And since then, other brain abnormalities have also been identified, such as abnormally formed or absent structures, like agenesis of the corpus callosum. The illustrations on the slide demonstrate some of the changes seen with microcephaly, and it really emphasizes that microcephaly is just a manifestation of abnormal brain development. The picture on the upper left depicts an infant with microcephaly compared to an infant with a typical head size below. And in the CT scan shown here, you can see some of the abnormalities I just mentioned, such as intracranial calcifications and ventriculomegaly shown at the top. Below are head CT scans of a typical newborn for comparison. Recently, CDC conducted a systematic evaluation of the evidence and concluded that there is a causal relationship between prenatal Zika virus infection and microcephaly, as well as other serious brain anomalies. In May, CDC released a new perspective in the New England Journal of Medicine on risk estimates for microcephaly related to Zika virus infection in the first trimester of pregnancy, using data from Brazil. The estimated risk of microcephaly related to Zika virus infection in the first trimester of pregnancy was approximately 1 to 13%. However, there's really not enough data to estimate what the ongoing risk is in the second and third trimesters. And despite limitations and uncertainties in this estimate due to the limited available data, these estimates can still assist public health planning as the Zika epidemic continues. In addition to microcephaly, there are other problems that have been detected in pregnancies and among fetuses and infants infected with Zika virus before birth, such as miscarriage and stillbirth, as well as absent or poorly developed brain structures, defects of the eye, hearing deficits, and impaired growth. And while the evidence supports a causal link with microcephaly as well as other severe fetal brain defects, many questions still remain. There is much that we still don't know. For example, what is the full range of potential health problems that Zika virus infection may cause? For example, does Zika cause learning problems later in life? And what is the level of risk from Zika infection during pregnancy? That is, if a woman is infected, how often will her fetus have Zika-associated problems? And when during pregnancy does Zika virus infection pose the highest risk to the fetus? And what are other factors, such as other infections that occur at the same time, that might affect the risk for birth defects? Answering these critical questions is a focus of our ongoing research and may help improve our prevention efforts and ultimately help reduce the effects of Zika infection during pregnancy. Every new finding from a published study and each new data point collected feeds into what we know about Zika and directs our public health action. And we're rapidly translating new findings into messages for the public and updated clinical guidance. And we are committed to sharing what we know when we know it. To that end, CDC has published updated clinical guidelines for healthcare providers caring for pregnant women, babies, and children with possible Zika virus infection, and for couples who are interested in conceiving. These guidelines are available on CDC's website and are updated as new information becomes available. In addition, CDC maintains a 24/7 Zika pregnancy hotline for healthcare providers of pregnant patients with possible Zika virus infection. And through this service, we are available for any concerns about clinical management, as well as to answer questions about the U.S. Zika Pregnancy Registry, which I will talk about in a bit, by telephone or email consultation. In addition, we are translating our clinical guidance into tools and materials for healthcare providers to use, and you can see some examples on the screen. These are also available on our website. Next, let's talk about the most updated guidance for pregnant women. CDC has made updates to the clinical guidance of pregnant women, which includes the expansion of real-time reverse transcription polymerase chain reaction, or RT-PCR testing. And reasons for the expanded PCR testing include emerging data that's indicating that Zika virus RNA can be detected for prolonged periods in some pregnant women, but to also increase the proportion of pregnant women with Zika virus infection who end up receiving a definitive diagnosis. Testing options will vary according to the type of possible exposure and timing relative to the last possible exposure. Here, possible exposure is defined as either travel to or living in an area with Zika virus, or sex without barrier protection, such as a condom, with a partner who has traveled to or lives in an area with active transmission of Zika virus. Therefore, it's important to note that all pregnant women should be asked at each prenatal visit if they have had one of these possible exposures. The updated testing and interpretation recommendations for pregnant women with possible exposure to Zika virus is depicted in this flowchart. Although I won't be going through it in any detail today, it is available on the CDC website. Symptomatic pregnant women who are being evaluated less than 2 weeks after symptom onset should receive Zika virus RT-PCR testing of both serum and urine. However, if the evaluation is occurring 2 to 12 weeks after symptom onset, Zika virus immunoglobulin or IgM testing should be performed first. Then, if this result is positive or equivocal, serum and urine RT-PCR should be performed. Now, for asymptomatic women who live in areas without active Zika virus transmission and are being evaluated less than 2 weeks after their last possible exposure, RT-PCR testing again should be performed. But if the RT-PCR testing is negative, a Zika IgM test should be performed 2 to 12 weeks after the exposure. And for those who live in an area without active Zika virus transmission but are being evaluated 2 to 12 weeks after their last possible exposure, Zika virus IgM antibody tests should be performed. Again, if this test is positive or equivocal, serum and urine RT-PCR needs to be performed. And finally, for those pregnant women who live in areas with active Zika virus transmission, Zika virus IgM antibody testing should be performed as part of their routine obstetrical care during both the first and second trimesters, with immediate RT-PCR testing of women who end up being IgM positive or IgM equivocal. Testing is being performed at CDC and most state health departments, as well as at several commercial laboratories. Through emergency use authorizations, CDC continues to expand sites for laboratory testing, and healthcare providers are advised to contact their state or territorial health department to facilitate diagnostic testing, as well as to report cases. Prevention. On an individual level, pregnant women can take action to protect their pregnancies. CDC recommends that pregnant women not travel to areas with active transmission of Zika virus. But if a pregnant woman must travel to an area of active transmission, she should really talk to her healthcare provider before departing and strictly follow steps to avoid mosquito bites and prevent sexual transmission during her trip. CDC has just updated the guidance on how to prevent sexual transmission of Zika virus. Couples in which a woman is pregnant should use barrier methods consistently and correctly, or abstain from sex for the duration of the pregnancy. Couples in which a partner had confirmed Zika virus infection or clinical illness consistent with Zika virus disease should consider using barrier methods consistently and correctly in addition to other birth control methods used, or abstain from sex as follows. Men with Zika should follow these precautions for at least 6 months after onset of illness, while women with Zika should follow these precautions for at least 8 weeks after onset of illness. And couples in areas without active Zika transmission in which one partner traveled to or resides in an area with active Zika virus transmission but did not develop symptoms of Zika virus disease should consider using barrier methods or abstaining from sex for at least 8 weeks after that partner returns from the Zika-affected area. For couples who live in an area with active Zika virus transmission, might want to consider using barrier methods or abstaining from sex while active transmission persists in that area. It's recognized that counseling women and men who live in areas with active Zika virus transmission is quite challenging, and there are multiple factors that need to be taken into consideration. It's recommended that couples in these areas talk with their healthcare provider if they are interested in conceiving. To that end, CDC has created a tool to aid healthcare providers in counseling women and men who are interested in conceiving and who live in areas of active Zika virus transmission. This guide is available at the website on the screen and includes key questions to ask patients as well as sample scripts to help facilitate discussion. Next, I want to switch gears a little bit and discuss infection control in the healthcare setting through the use of standard precautions in the context of Zika virus. At this time, there have been no reports of transmission of Zika virus from infected patients to healthcare personnel or other patients in the healthcare setting. However, Zika virus has been detected in multiple body fluids, including blood, amniotic fluid, urine, saliva, and semen, as previously mentioned by Susan. Healthcare personnel must adhere to standard precautions in all healthcare settings. This is already existing guidance, but Zika provides an opportunity to emphasize the importance of following these existing protective recommendations. In particular, where healthcare personnel have the potential for exposure to large volumes of blood and body fluids, such as on labor and delivery and other clinical settings, routinely adhering to standard precautions cannot be overemphasized. CDC recommends standard precautions in all healthcare settings to protect both healthcare personnel and patients from infection with Zika virus, as well as from bloodborne pathogens, for example, HIV and hepatitis C viruses. Standard precautions are the common sense approach to infection control and are a group of infection prevention practices that apply to all patients, regardless of suspected or confirmed infection status, in any setting in which healthcare is delivered. They are based on the principle that all blood, body fluids, secretions, excretions except sweat, and non-intact skin, as well as mucous membranes, may contain transmissible infectious agents. The goal of standard precautions include preventing direct contact between a patient's body fluids and healthcare personnel's mucous membranes, including eyes, or broken skin. Preventing healthcare personnel from transmitting potentially infectious material from one patient to another, and avoiding unnecessary percutaneous exposure to contaminated sharp implements. The type of standard precautions used should be based on a risk assessment by the individual healthcare provider. Standard precautions include hand hygiene, appropriate selection of personal protective equipment or PPE, safe injection practices, environmental hygiene, namely the safe handling of potentially contaminated equipment or surfaces in the patient environment, and respiratory hygiene and cough etiquette. Good hand hygiene, including the use of both alcohol-based hand rubs and hand washing with soap and water, is critical to reduce the risk of spreading infections, including Zika. In the absence of visible soiling of hands, approved alcohol-based products for hand disinfection is really preferred over soap and water because it can increase compliance with recommended hand hygiene practices by requiring less time, irritating hands less, and facilitating hand hygiene at the patient bedside. Key situations where hand hygiene should be performed include before touching a patient, even if gloves will be worn, and prior to putting on those gloves, after contact with the patient or the patient's immediate environment, after contact with blood, body fluids, or excretions or wound dressings, and finally after glove removal. Personal protective equipment, or PPE, is intended to protect healthcare personnel from exposures to or contact with infectious material, such as through breaks in the skin, mucous membranes, or eyes. Examples of PPE include gloves, gowns, face masks, face shields, and goggles. Facilities should assure that there is sufficient and appropriate amount of PPE available and readily accessible to healthcare personnel. And healthcare personnel need to be educated on the proper selection and use of PPE so that they can assess their personal risk for exposure to blood and body fluids based on the type of patient contact and the nature of the clinical procedure or activity, and then in turn select the appropriate PPE based on that information. Healthcare personnel should anticipate potential exposures and the opportunities for splashes of these fluids. And appropriate PPE should be worn to protect mucous membranes, including eyes, accordingly. In addition, all healthcare personnel on a team that are involved in the same procedures need to use the same types of PPE. Injection safety practices intended to prevent transmission of infectious disease between one patient and another, or between a patient and a healthcare provider during preparation and administration of parenteral medications. Selected key recommendations include the use of aseptic technique when preparing and administering medications, never administering medications from the same syringe to multiple patients, even if the needle is changed, dedicating multi-dose vials to a single patient whenever possible. If multi-dose vials will be used for more than one patient, they need to be restricted to a centralized medication area and really shouldn't enter the immediate patient treatment area. Breaches in injection safety, such as syringe reuse, have been responsible in numerous instances for placing thousands of patients at risk for bloodborne pathogen transmission, such as hepatitis in the healthcare setting. Standard precautions also include environmental cleaning, the appropriate reprocessing of medical equipment, and respiratory hygiene and cough etiquette that should be observed in all healthcare settings, but is not necessarily specific to Zika. It is important for all occupational exposures to be reported to a facility's occupational health clinic so that appropriate assessment of healthcare personnel can occur and any systemic safety risks can be promptly addressed. And education and training on the principles and rationale for recommended practices is absolutely critical to facilitate appropriate decision-making and promote adherence. Any barriers to the routine use of standard precautions need to be identified and addressed immediately when they are identified. Additionally, facility, nursing, and physician leadership is critical for instituting infection prevention policies and promoting a culture of routine use of and adherence to standard precautions. What can you do? We'll end the presentation by discussing the U.S. Zika Pregnancy Registry and your critical role in supporting this effort. And as we've discussed, Zika virus infection during pregnancy has been linked to adverse outcomes. But despite these observations, we still know very little about the risks of Zika virus infection during pregnancy. So CDC has established the U.S. Zika Pregnancy Registry to help monitor pregnancy and infant outcomes, to learn more about the timing, absolute risk, and spectrum of outcomes associated with Zika virus infection during pregnancy, to help inform clinical guidance and direct public health action. The registry is a supplemental surveillance effort coordinated by CDC, but it's really dependent on the voluntary collaboration of clinicians and state, tribal, local, and territorial health departments. Similar surveillance systems have been established in Puerto Rico and Colombia. The registry includes pregnant women that have laboratory evidence of Zika virus infection and exposed infants born to these women. If infants with previously unrecognized congenital Zika virus infection are identified, their mothers will be included in the registry retroactively. But it is worth noting that the Zika Pregnancy Registry inclusion criteria are broader than the current Council of State and Territorial Epidemiologists interim case definition. The registry includes pregnant women with positive or inconclusive Zika test results, regardless of whether symptoms are present. And it also includes all children born to these women, but not only those with identified congenital infection. All of you can really support the registry by spreading the word about its importance and working with your health department to report cases and collect clinical and follow-up information, which may include medical record review by public health officials. If you'd like more information about the U.S. Zika Pregnancy Registry, please feel free to call the Zika Pregnancy Hotline or email us at zikapregnancy@cdc.gov. And all of the materials described in this presentation can be found at the link listed on this slide. Our current understanding of Zika is a result of the work of many, many people. Thank you to all of our collaborators, and most of all, thank you all for listening tonight. I'm going to turn it over to Angela now. Thanks.
Thank you, Dr. Perkins. We thank everybody for joining tonight. We've received quite a few questions throughout the webinar session, and we will do our very best to answer as many as possible. And if not, we will follow up with responses via email following. Our first question tonight, and I'm putting it out there for either Dr. Hills or for Dr. Perkins. Once a person has been exposed to the Zika virus, is there a possibility of natural immunity?
So this is Susan. Yes, so like many arboviral diseases and other infections for that matter, if somebody is infected, then we assume that immunity will be lifelong.
Great, thank you. What kind of protection would a physician need to care for a patient who has Zika?
This is Karen Perkins. So as we've mentioned, really standard precautions is necessary in all healthcare settings, including in situations where a provider is taking care of a patient with known or suspected Zika virus. And the type of protection that the healthcare provider should use is really dependent on the clinical scenario and the patient interaction and or procedures that are going to be performed. So it really requires thought into risk assessment of what kind of exposures will be faced in a particular clinical scenario.
Our next question. We know what to tell pregnant women to do to decrease risk, but what are the recommendations for women planning on becoming pregnant within the next year? Is there still no known implications for future pregnancies following clearance of Zika virus? And would you recommend that women expose themselves so that they are immune prior to conceiving?
This is Karen Perkins. Currently, we actually don't have any evidence to suggest that past Zika virus infection poses an increased risk of birth defects for future pregnancies. And in terms of considering conception in general, this is a highly personal and complicated decision and should be made in concert with discussions with a person's healthcare provider.
Thank you. Our next question. How long do other viruses stay transmissible in the blood of humans? And are there other flavoviruses that have chronicity?
Sorry, could you repeat the first part of that question?
How long do other flavoviruses stay transmissible in the blood of humans? And the last part was, are there any flavoviruses that have chronicity?
Right, okay, thank you. A couple of responses to that question. So it can be variable typically. So with Zika, for example, we consider that the virus is present in blood up to about 14 days. For transmission to occur, it of course needs to be at a level where if the mosquito bites that person, that they become infected with the virus, and then the subsequent extrinsic incubation period occurs. For other periods, for other flaviviruses, the periods of viremia are very considered to be round about that period, about 7 days, but can be variable. Of course, not all flaviviruses are transmitted in that same way. So, for example, Japanese encephalitis virus, another flavivirus, the mosquito picks up the virus from an animal, and humans are dead-end hosts. So the flaviviruses are a different group. So other flaviviruses, yellow fever, JE, dengue, West Nile virus, we have no clear evidence of chronic conditions associated with these flaviviral infections.
Thank you. How valid is the use of DEET insect repellents for the prevention of these diseases?
So the EPA is responsible for evaluating and considering the effectiveness of insect repellents. And as you probably know, there are 4 different repellents that are recommended. They include DEET, picaridin, the component in the insect repellent DEET, picaridin IR3535, and oil of lemon eucalyptus. For the EPA to recommend these insect repellents, they go through studies that are submitted, and they have been shown to be effective for mosquito-borne diseases. Specifically for Zika virus, we can't say there's no specific data for Zika virus. However, we do know based on the data that have been gathered for other arboviral diseases that they're certainly effective in repelling mosquitoes and therefore reducing the risk of mosquito bites where the transmission can occur.
Thank you. Our next question. What is the incidence of microcephaly in fetuses of infected women?
This is Karen Perkins. We still don't have a great estimate at this point, and we're working on modeling to come up with those estimates. And the data that we do have is really specific to the first trimester, but we're continuing to analyze the data as it comes in.
Thank you. Our next question, is it possible that 6 months may not be long enough for a couple to wait to attempt to conceive after the male has symptomatic Zika infection?
Based on the available data, our recommendation is for 6 months. However, there are ongoing studies looking at persistence of the virus in semen samples, and as that data again comes in, we'll adjust our recommendations.
Thank you. What screening test is being done, or screening test is being used for blood donations?
There are NAT tests that are being used and developed specifically in the context of the Zika virus outbreak. Roche has developed the screening NAT.
Thank you. If someone is infected with Zika and then is bit by a mosquito that's not of the Aedes species, can the mosquito become a carrier and infect persons?
So the two main vectors of Zika virus are Aedes aegypti and Aedes albopictus. There was some reports out of Brazil about Culex being a potential vector, and studies, as I understand it, that have been done in the US have not supported that at this point. So clearly Aedes aegypti and Aedes albopictus are the two important vectors. In terms of transmission, when the mosquito bites somebody who is viremic and picks up virus, there then is an extrinsic incubation period, which is approximately 10, potentially up to 15 days in the mosquito. And then the mosquito at that point is capable of transmitting the virus. Once the mosquito bites somebody, there of course is then the intrinsic incubation period, which we know based on some modelling and review of data from this outbreak is probably between 3 and 14 days. And then at that point, if somebody is symptomatic, they'll begin to show symptoms.
Thank you. Would you be able to comment on how we should counsel parents of children worried about Zika virus? I'm a pediatrician and feel this issue is more an issue for the parents themselves than an unborn fetus. But once the child is born, it is a mild illness that generally does not warrant screening in asymptomatic parents. Is that correct?
So this is Karen Perkins. From what we do know currently, the clinical manifestation in children seems to be very similar to the clinical manifestation in adults. So at this time, we have no evidence to suspect that it's any different. However, we are continuing to monitor this in places where there is active local transmission, such as in the countries in Central and South America. And we're following these cases to see if there are any other effects that are different than seen in adults.
Thank you. This question is for Dr. Hills. Do you know about insurance coverage of the commercial Zika PCRs? Our state Department of Public Health is restricted in their testing capacity for pregnant women.
Sorry, I do not know about insurance coverage.
Thank you. Are healthcare providers to pregnant women at risk for this virus?
This is Karen Perkins, and just repeating what I've mentioned already regarding healthcare providers and exposures. Again, they're not at risk for contracting the infection as long as the routine standard precautions are exercised. And again, we have no reports to date of any transmission in the healthcare setting.
Great, thank you. Does infection in humans lead to natural development of viral antibodies that will ensure safe pregnancy?
So this is Susan. I think that question is similar to one that was asked earlier in terms of immunity following Zika virus infection. Though it cannot definitively be said that every person who gets a Zika virus infection will be protected lifelong, and of course there's individual variations such as people becoming immunocompromised, etc. It's generally considered that once a person has had an infection, they will develop lifelong immunity, and I'm not sure if Dr. Perkins wants to comment specifically on subsequent pregnancy.
Thank you, Dr. Hills. Yeah, I would kind of echo that, and kind of similar to the previous question. At this time, there's no concern that prior infection is going to affect any future pregnancies adversely.
Thank you. We have time for just a few more questions. Can a woman safely assume that if her travel to a Zika area was greater than 12 weeks, she can safely become pregnant or should have screening? So the question again was, can a woman safely assume that if her travel to a Zika area was greater than 12 weeks, she can safely become pregnant or should have a screening?
Based on our current evidence and current data, the recommendations are an 8-week waiting period. She should be safe after 8 weeks after exposure if she herself traveled.
Great, thank you. Do the larvae of infected mosquitoes carry the virus?
So that's a good question. There's ongoing mosquito studies considering various issues with mosquitoes. We know with dengue as an example that overwintering can probably occur, but I would have to ask an entomologist for that, for specifically information on mosquito studies and data.
Thank you. Does a patient infected with the Zika virus ever, quote, clear the virus from her bloodstream?
So if somebody is infected with Zika virus, we typically know that the period of time where there's detectable viral RNA is roughly about 2 weeks. The interesting finding that has come to light during the current Zika virus outbreak is that in pregnant women, there has been a longer period when viremia or viral RNA has been able to be detected. But we would certainly assume that the virus is ultimately cleared in response to the infection. There's an antibody response, and neutralizing antibodies are generated, and ultimately that would clear the virus.
Thank you. If this virus has been present several years, why do we see the malformation in babies of pregnant women now?
So the virus has been certainly circulating in Africa and Asia for many, many, many years. As I said earlier, not only are there other arboviral diseases such as dengue and chikungunya that can present in a very similar way, but there is also a variety of other viral infections that can present measles and adenovirus and enterovirus and various infections. So firstly, just even in terms of identifying Zika virus infections, that can be very difficult. Secondly, testing has been very limited accessibility in Africa and Asia. What we know about Zika virus is that when serological testing is done, there is a high rate of cross-reactivity with dengue antibodies, and so that could, a person who had Zika virus infection could be considered to have dengue virus infection if complete dengue and Zika virus testing wasn't completed. Finally, because the circulation of the virus has been in Asia and Africa, there are many, many causes of microcephaly, and therefore somebody who had a rash illness during pregnancy, it may not even be linked to a subsequent microcephalic birth, and because there are many both infectious and toxic and other causes that could result in that microcephalic birth, I think the surveillance has not allowed detection of that outcome, but it certainly is an interesting question. The other factor that we don't know is if the level of transmission in some of these areas is high, so that women or girls are being infected early and therefore are immune, and therefore by the time they're considering childbearing, they are already immune to Zika virus, and so there has been a lower rate of infection during those childbearing years. But that, of course, is merely a hypothesis.
Thank you. We are at time. In fact, we're a couple of minutes over, so I'd like to thank everybody for chatting in their questions today. Unfortunately, this is all the time we have, but this webinar has been recorded and will be posted following on the AMA website, and we will circulate the link to all the participants, and we encourage your other colleagues to reference it. And with that, I'd like to thank our speakers, as well as all of you, again, for taking the time to join us today and for your commitment to keeping your patients safe. Good night.